Okay, so this is week 12. Week 12, we're going to focus on geriatrics and dementia related to geriatrics, ageism, a lot of issues around geriatrics. Questions? The readings, big things got the readings. Going home, that's a good reading about a student clinical capstone. And then the reading of the Sue Miller reading about her father. The Sue Miller reading about her father, I think, is very typical of a lot of dementia patients, all the stuff he was experiencing. As he experienced more and more of it, you see a lot of that. You're not familiar with that. A lot of delusions. Use of humor, I mean, that's kind of a controversial kind of thing. At times people say you're making fun of them, but humor is kind of the way people kind of cope on both sides, like the caregivers and the client. Wandering, very, very common. As folks get older, deterioration of their brain, emotional changes. They get up and they wander at night. It's a lot of issue. A lot of times you'll be dealing with as a client, as an occupational therapist. And we'll talk about some strategies for that and those kinds of things in a minute. Remember, it's a brain deterioration, so they're losing the executive function of the front part of their brain, so they're losing kind of impulse control. So all kinds of appropriate kind of stuff. Lost recognition is a big one. Lost empowerment, lost meaning. All those series of losses that could have gone through with a dementia patient. Aging and isolation. Aging isn't necessarily a bad thing. As an OT, we're seeing a lot of the bad sides of it because when we're seeing somebody, usually there's some problems. But there are some things that go along with aging that are not so pleasant, to be honest about it. Discrimination, especially from younger folks, not wanting to go there, not wanting to think, not about getting old and dealing with that. Poverty, geriatrics, shrinking resources, isolation, talked about loss of loved ones, friends. Modern families very isolated, disconnected, not so much support networks for the old as there used to be. Depression, very, very common. Depression and anxiety with the geriatric population. We'll see a ton of this. Part of it is the deterioration of the brain as we get older. Another part of it is just lost a lot of those roles, those occupational roles that are so important to give our life meaning. Trying to find new roles and new meaning. Ageism, quality of life, be impacted as you get older, loss of resources, social supports. Talked about that. Lost voice, not heard so much anymore. Discrimination in the workplace, harder to get jobs and continue working. These are, I think, interesting to kind of look at because these are kind of older folks that kind of defy the stereotypes. And I think as an OT, we kind of lose perspective. Most people age productively and age quite well and don't end up in nursing homes. And these are kind of folks that are kind of just continue to do their thing, continue to find their occupation. These are a series of pictures and little stories that this guy, photographer Jason Smith, did. I think they're kind of good to kind of see on the flip side of things. This guy, Andy Gove Stonington, he's 88-year-old lobsterman. He's in pretty good shape. I've worked with a lot of lobstermen. They don't seem to age like everybody else. I don't know what it is, but they seem to. I think it's just the physical, vigorous lifestyle. This guy is still flying at 85. Started in 1952. This woman, Anne Bradford, loves to hike. Has hiked all the peaks of Acadia. Finds it very inspirational. She looks in great shape. This woman, Julian Rose, is 88, still a very avid biker, cross-country skier. Just good examples of productive ageism. What aging can be. It doesn't have to be what we see a lot of in nursing homes and that sort of stuff. But then flipping it back the other way, the kind of patients we're seeing a lot with age as they get older is dementia, Alzheimer's, that sort of thing. Just kind of refresher on Alzheimer's before we get into the nitty-gritty of what OTs do and just ideas and strategies of things you can do. Mild, moderate, and severe kind of goes through these different stages. So it kind of spreads throughout the brain. Remember, if you start messing around with the brain, does all kinds of things to people's behavior. Obviously, judgment and memory, a lot of stuff around depression, impulsivity. But it seems like mental illnesses are kind of related to brain deterioration. Looking at again through the patient's perspective, as we try to in this class, the brain and behavior affects the behavior. Perceptual damage, brain perceptual damage is uneven. It's not like a progressive kind of thing. It's kind of all over the place. Every patient can be very different. When we say perceptual damage, it can be quite significant. I had clients that in a nursing home, they're walking along and they see, say it's a white tile and it shifts to a black tile, and they kind of freeze up, and they ask them, why did you stop? And they kind of think the black tile is like a hole in the ground. Brain deterioration, perceptual stuff. Loss of one cognitive skill can impact other skills. Psychiatric problems go hand in hand with brain damage. Voices, acting, delusional kind of behaviors, delirium, that sort of stuff, all goes to that brain deterioration. A person's feelings impact his or her behavior, especially pain can affect bizarre behaviors. Just kind of tease out, are they in pain, that sort of thing. Okay, so these are kind of solutions. This is all from a... Okay, before we get into that, let's kind of talk about the exploding kind of crisis in healthcare. We talked about the kind of oncoming tsunami with dementia and all that sort of stuff that's coming with all these baby boomers getting older. A lot of these issues that you're dealing with as an OT, these things that you have to kind of problem solve and help caregivers, clients find solutions to, refusing to take a shower, getting up at night, wandering, incontinence, this idea of wanting to go home, even when they already are home, depression, debility, talk about perceptual stuff, caregiver burnout. A lot of times you must feel like you're treating the caregiver as much as you are the client. Sundowning, the sun goes down, agitation, up, wandering, that sort of thing. These are some ideas. A lot of these are from a book. It's an amazing little book. If you're working with a lot of clients with Alzheimer's, I highly suggest it because it's very practical. It gives you just simple solutions and tips. It's called the 36-hour day. 36-hour day. It's like a family guide. What it is tips and strategies people have found that work with Alzheimer's clients. All these different categories. Very vast and extensive. Great resource. So when we think about Alzheimer's clients, from an OT perspective, some of the things that we can do for care with them, a lot of the times comes down to the ADL, getting dressed in the morning. The caregiver is doing so much work, it's exhausting, they're getting burned out. They come to you, do you have any suggestions, solutions? My mom just can't seem to do any part of dressing, and I'm doing it all. Tapping into habits. Talked about this way back in wellness. Habitual patterns. A different part of the brain that's not damaged. You can kind of do things kind of unconsciously. We're going to tap into this unconscious doing of things, and you're not using the damaged parts of your brain, parts that are just kind of simple routines, is to be really, really obsessive about routine. Doing everything exactly the same way every day, very consistent. We're going to get dressed every morning at 8 o'clock. We're going to start with your right sock, then your left sock, and then your right shoe, your left shoe. Keep doing that. Make it routine day after day after day. The client, no matter how much brain damage they have, really severe brain damage, will start to pick up on that. And what they'll do is they'll start to do more of it themselves. Folks with brain damage in general, and Alzheimer's for sure, thrive on routine. They aren't children, but if you think of children, how they thrive on routine, a lot of Alzheimer's clients thrive on routine. Sequencing, simplify the clothes, basic kind of stuff, reversible clothes. Avoid busy patterns. Why busy patterns? Again, think the perceptual deficits. They have a blouse with all kinds of flowers on it. They're trying to get their arm through that hole. Can make it a lot more difficult for them. Style, we talked about that, may or may not be important. They may get to the point they don't care, so you can simplify things, make it easier to dress. Showering, so a common thing. All Alzheimer's clients do not want to get wet, do not want to do the shower anymore. Simplify where it's possible. Keep it really simple. Your commands simple. The steps, the routine simple. Your demeanor. People kind of feed off your demeanor. If you're calm, gentle, and quiet, they're going to be calm. If you're revved up, nervous, anxious about everything, they're going to pick up on that. Privacy, keeping them in a robe and just washing under it versus going into the shower. Try to follow that old routine as much as you can and be consistent. Being a little more assertive, avoiding questions like, do you want to take a bath versus let's step into the shower now, let's get washed up, that sort of thing. Again, the perceptual deficits can really come to play in a bathroom kind of thing. Safety, safety, safety. Never leave the person alone or turn away from them for a second. Things can happen in a hurry, believe me. Memory, obviously this is one of the bigger ones. Losing that short-term memory. Memory aids can work, or they may not work. We would think, putting stickers around, calendars, that sort of stuff. If you're kind of able-bodied and have a lot of cognition intact, that can work great. But if it's more advanced, it may not get you anywhere. Again, routine, simple lists, simple labeling, definitely worth a try. Good way to kind of tap into how much potential the client has is to give them the ACL. They can kind of determine that with that. And then a lot of emotional issues. As this brain deteriorates, you can get clients that are combative, get very emotional. So a big thing with that, a client is getting very emotional, consistently emotional. Excuse me. What are the triggers for that emotional reaction? Is it a noise? Routine change? Difficult tasks? Sometimes working in groups can do it. Too many questions. Questions can be challenging if you're impaired. Bathing, we talked about that, can be a big thing. Being rushed. Fatigue. Older clients can get fatigued really quickly, easily. Being treated like a child may not work. Pain, we talked about that underlying medical issue can be the source. You have to kind of be like a detective and figure out what is causing all this emotional outbursting. There usually is a good reason for it. A lot of times in my experience, it's just incontinence. They're wet, they need to be changed, or whatever it may be. Strong emotional reactions common. What helps? Going with the client versus constant reorientation. Here's an example. This is a strategy. This woman, she had her mother, she was living with her mother in her mother's house, and his mother kept saying, I want to go home. I need to go home. I need to go home. I'm not home. Take me home. This is not my home. So, versus this kind of fighting and saying, well, this is your home, and getting into this kind of verbal back and forth was going to get you nowhere. The daughter just, okay, we're going to go home. So they just got her in the car, drove around the block, came home and said, oh, we're home. And it worked. That kind of thing. Whatever works, and it's not harmful. It's kind of fair game in a lot of ways. Where the person, depending on where the person is at. Again, the routines, they're familiar. Break things down to simple steps. Fish tanks. This sounds weird, but just staring at fish tanks. A lot of nursing homes get fish tanks. Staring at that, staring at the fish in the water can be calming. Limiting activity when tired. Realistic expectations. Don't expect the person to do too much. Kind of slowing down and stopping before things escalate. Keeping a log of triggers to see what the pattern is. Physical contact, restraints definitely could set somebody off. Communication. Communication can be very, very challenging. Degrees of aphasia, not being able to explain, articulate what they want. That's important. They're trying to get across. Word finding, incoherence, babbling, carefully avoiding deficits. Different strategies. Help them point if they can't use the words or describe the word they can't express. Guess and confirm. They cannot communicate. Make sure to regularly check for warmth, skin breakdown, incontinence, facial agitation. See if you can figure out on your own why they're agitated, why they're trying to say something they can't seem to articulate. Issues with understanding. Common difficulties include quickly forgetting what they understood. You teach them something and they have it and it just goes. Significant difference between reading out loud and comprehension. They may seem like they can read, but they really can't understand what you're reading or what you're giving them as a handout. Telephone can be a big issue in terms of understanding. Cell phones. Strategies for system comprehension. Make sure they're hearing you. They may sound like they're hearing you, but they're really not hearing you. Change the pitch or tone of your voice. Reduce distractions. Use short words, simple sentences. One question, one task at a time. Speak slowly and calmly. Smile. Making direct eye contact. Again, that can feed off how you're feeling. Touch, pointing, sensitive to body language. Caregiver burnout. Dealing a lot with this with dementia clients. Different strategies. Caregiver concerns with social supports. Big one. Rest and knowing limitations. Everybody has limits. Maybe it's time to think about a placement in a nursing home. Just everybody's at their limit. Solving problems one at a time, breaking them down versus getting overwhelmed. Being creative in problem solving, like the driving around the block example. Looking to that resource, the 36-hour day, a lot of ideas in there. Again, structure and routine, keeping the person active within the limits of your energy and resources. We all have limitations. Smart home technology is a great new thing for dementia clients, Alzheimer's clients. Going home with the right technology and supports. It's almost a matter of if you have the money, you can make it happen. Everybody has the dignity of risk in terms of going home versus staying in a nursing home. I don't know how many of you worked or been in nursing homes. You'll be a lot in nursing homes this summer. They're not necessarily a pleasant place to be in a lot of cases, very short-staffed. People fall a lot in nursing homes as well. Is that really an alternative versus the home? You have to kind of weigh those pros and cons. Think about all the smart tech the person can afford it that can really maybe make the person safe at home versus placement. Smart stoves, turn off on by themselves. Obviously Alexa. Smart tracking that's on their feet, tracks where they're going if they're wandering. Different kinds of pill kind of things. All kinds of environmental controls, iPad, endless possibilities, surveillance cameras, motion detectors. Just endless possibility. You're just warning about this stuff. Just go into the smart home section in Home Depot. Just check this stuff out. This week, things a little bit different in terms of the homework. Due 414, Simulation 3 homework. Just for the following students, we're going to go back and forth. Some students this week and then the rest of the students the following week. So these are the stories you have to read with the questions. These students are doing the Harold stories. These students are doing the Ruth story. Let's maybe have questions about that.